Welcome to the NCLEX Bootcamp series on the next generation NCLEX. In this video, we're going to walk through a full-length next-gen case, and I'll show you how I would approach this as a nurse and how I would think about this case as it unfolds. So let's get started. The first thing you want to do is read through your client data tabs very carefully, and if you review our detailed walkthrough on approaching next-gen cases, you'll remember that it's really important here to keep this picture of this client in mind as the scenario unfolds, because that's going to help you answer these questions. So I'm going to highlight those parts that really stand out to me as being abnormal or significant. The nurse in the emergency department is caring for a 72-year-old male client. A 72-year-old male client comes to the emergency department with left lower quadrant abdominal pain, nausea, and vomiting for the past 3 hours. He has a history of obesity and hyperlipidemia. He denies previous gastrointestinal problems except occasional constipation. He reports small streaks of blood present in the stool. He expresses pain level as 7 out of 10 in the left lower quadrant of his abdomen. The pain is persistent without any radiation or alleviating factors. Abdominal tenderness is noted on palpation of the left lower quadrant. Bowel sounds are hypoactive. Client is alert and oriented to person, place, and time. And then for our vital signs, his temperature is a little bit elevated at 100.1 Fahrenheit or 37.8 centigrade. He's a little tachycardic with a pulse of 104. His respiration's 20. His blood pressure a tiny bit elevated at 130/83. And then his pulse oximetry reading 97% on room air. So now I want you to picture this elderly gentleman, poor guy, who's having severe pain and tenderness in his left lower quadrant. For 3 hours now, he's been nauseous, he's been vomiting, and now he also has this blood in his stool, and when you listen to his abdomen, his bowel sounds are hypoactive. He's febrile, tachycardic. So we're asked in our first question to recognize cues by dragging the top 5 client findings that would require follow-up to the box on the right. So here, we're wanting to follow up on those things that are abnormal, unexpected findings that take priority. These are the top 5 findings, things you can't wait to address. So let's just take these one at a time. So his pulse of 104, that is elevated. I'm not sure yet if that's expected or unexpected. He's got 7 out of 10 pain, so this could be due to his pain. I'm going to hold off on calling that a top 5 finding. I would expect this to improve once his pain is controlled. The abdominal pain, 7 out of 10. So abdominal pain is kind of a challenging symptom to approach because it could be anything. It could be something in his GI tract, sure, and this certainly looks like it might be because he also has blood in his stool. But it could also be a symptom of a myocardial infarction or an aortic dissection or something really life-threatening, especially when it is this severe and accompanied by nausea and vomiting. So definitely problematic and something we want to follow up on. I don't want to just let him stay here in pain. If nothing else, I want to treat that pain with an analgesic, right? So yes, I'm pretty sure this is going to be something that I follow up on. Similarly, nausea and vomiting. He's been vomiting for 3 hours. And you'll remember that the very elderly and the very young are especially sensitive to becoming dehydrated with fluid losses. So I'm going to follow up on that. Hypoactive bowel sounds. So remember, when we're listening to bowel sounds, that's telling us about the gastrointestinal motility. If those are hypoactive, this could potentially mean that he has some ileus, some decreased motility, some decreased perfusion to the intestines. That would certainly manifest as this pain, nausea, and vomiting. So I'm concerned about that. That could mean he's not getting enough blood flow to his intestines, and that would make this then an issue of circulation, right? So that is going to be in my top 5. Presence of blood in the stool. It says here these are small streaks. I don't have any lab results at this point yet in the case, so I don't know if this is a gastrointestinal bleed and he's quickly hemorrhaging and would require a blood transfusion, or if it's something benign. But because it has the potential to be a gastrointestinal bleed, it's something that I want to be concerned about as a potential circulation issue. Okay, now we've been kind of holding off on addressing his vital signs because we're not sure how much of this is just related to his pain, because naturally, if someone is experiencing severe pain like this, they're going to have an elevated heart rate and an elevated blood pressure. And I've got 4 of my 5 findings, so I'm really just looking for which one of these 3 is going to be the most concerning to me. And of them, I think if I was worried about this vomiting having made him dehydrated, I would see a high heart rate like that, but I would also see a lower blood pressure and then some other signs of poor perfusion, like a slow cap refill or thready peripheral pulses or mottling in his extremities. None of those symptoms are described here, so I'm not too concerned about these vital signs, the high blood pressure and the high pulse, because that's most likely a manifestation of his pain. But then when I look at the temperature, 100.1, now this is becoming really concerning for some infectious or inflammatory process. So I'm going to include that one in my top 5. And I'm satisfied that these are the 5 I'm going to follow up on. There's something I want to do about each of these findings. I need to figure out if this hypoactive bowel sounds is hypoperfusion to his intestines. I need to make sure he's not having a GI bleed. And if nothing else, I need to give him an antipyretic to treat his fever, an analgesic for his pain, and an antiemetic for his nausea and vomiting. And we'll see that, yes, we got each of these 5. So now we're going to move on to the next question in the case. And your second question is going to be analyzing these cues, or then considering what could they mean, what disease processes would create these findings. And so our case is unfolded. We're told that we have new laboratory results from noon. So let's review those. We've got a white blood cell count, which is 15,600. So that's elevated. I'm going to highlight that. Our hemoglobin, 15.5. So that's in our normal range. We were somewhat concerned about this blood in the stool, but now I see he's not anemic. I'm less concerned about that. And then our platelets are normal. Now we're asked in the second question, for each client finding, click to specify if the finding is consistent with the disease process of diverticulitis, appendicitis, or ulcerative colitis. Each finding may support more than one disease process. You'll remember from our item types video that we approach this style of question by treating each column as its own select all that apply. But before we do that, I just want to consider what each of these disease processes has in common. And so quickly, I just want you to note they're all itises. We have a diverticulitis, an appendicitis, and an ulcerative colitis. So these are all inflammatory or infectious conditions of the GI system. And so we'll do a quick review of what each of these is, because that information is necessary to answer the question. You have to understand that disease process. So diverticulitis, you'll remember, is when some clients will have diverticulosis, where they have these outpouchings in their sigmoid and descending colon. And that can be completely asymptomatic. Most clients have no issue with this, don't even realize that they have it, and sometimes it's found incidentally when we're scanning their belly for something else. But it becomes problematic when they develop diverticulitis, and that's when that lumen of that outpouching becomes obstructed, and this gets swollen and painful and tender and can start to erode the blood vessels and cause blood in the stool. So now knowing that, let's treat this like a select all that apply. So diverticulitis, will it cause fever? Well, we just discussed how it's infection, inflammation, and anything that causes infection or inflammation can cause fever. So yes, I would expect to see that. With that swelling and diverticulitis, you're going to have erosion of those blood vessels. And you'll remember from anatomy, your descending colon tracks down the left side of your abdomen, and then your sigmoid connects it to your rectum. So right there, right before the rectum is where this is happening. So that blood is going to look more fresh in the stool and is more likely to appear as these streaks of blood that he's having. So yes, I would expect to see blood in the stool with diverticulitis. Being more common in elderly clients. Yes, being obese, which he does have a history of obesity, and then being elderly are the 2 major risk factors for diverticulitis. I think a close third is maybe a low fiber diet. So yes, I would expect this to be more common in elderly clients. It would be very unusual for a young person to have this. And then abdominal tenderness to palpation. We'll consider this together with the next one, left lower quadrant abdominal pain. So we already reviewed in the GI tract how this is happening in that left lower quadrant. And if it's inflamed, then it's going to be tender when you palpate it. Think of this like if you get a sunburn or a cut on your arm. It's really tender to the touch because of that inflammation. You have increased pain sensitivity in that area. So yes, I'm going to expect to see abdominal tenderness to palpation and left lower quadrant abdominal pain. Great, so let's move on. For appendicitis, same thing. Appendicitis, this is going to be in the right lower quadrant, if you remember there, McBurney's point, where the appendiceal lumen gets obstructed either by lymph tissue or feces, and then same sort of idea, that obstruction starts to build up pressure, inflammation, infectious material behind it with the fear that it might rupture. So an infectious inflammation process, yes, it's going to cause fever. Blood in the stool. So this is much further back in the GI tract. At this point, any stool passing by the appendix still has to go through your entire large intestine. So even if there might be a trace amount of bleeding at that site, you wouldn't see it as blood in the stool. And then being more common in elderly clients. So appendicitis is probably one of the more feared acute problems of the GI tract in young people, right? This is something that we really commonly see in children, in teenagers, adolescents, and young adults. So no, this is not more common in elderly clients, it's more common in young clients. And interestingly enough, because this is in that right lower quadrant and diverticulitis can look really similar in the left lower quadrant, diverticulitis is sometimes called like a left-sided appendicitis for that reason. So no, it's not more common in elderly clients. And then when we're speaking of abdominal tenderness to palpation and then left lower quadrant pain, we just discussed how this occurs in the right lower quadrant and is different from diverticulitis from that reason. So I'm not going to select this one, but abdominal tenderness to palpation is the hallmark of appendicitis. You might remember some of those special maneuvers you can do, like the Rovsing maneuver, where you palpate the left lower quadrant and then you have pain on the right side where that appendix is. So I'm going to have abdominal tenderness to palpation. It's just not going to be in the left lower quadrant. And then finally, ulcerative colitis. This is one of the two types of inflammatory bowel disease, with the other one being Crohn's disease. And ulcerative colitis being a problem primarily of the colon, it starts in the colon or the rectum and then ascends. So just like diverticulitis is happening in our very distal colon and the sigmoid and descending colon, that's the same place you're going to see these findings in ulcerative colitis. So inflammation, eroding the vessels, bleeding, happening in a similar place to this diverticulitis. So yes, it's an inflammatory process. We're going to see fever, especially during an acute flare of ulcerative colitis. Blood in the stool, same idea. It's damaging those vessels locally by ulcerating into the intestine wall, and we are going to see blood. In fact, a lot of blood. Sometimes nurses will be so impressed at the amount of blood in the stool for a client who has ulcerative colitis that they'll be afraid to give blood thinners. But if you're familiar with ulcerative colitis, they're very hypercoagulable and they really need those blood thinners when they're hospitalized. So yes, we're going to see blood in the stool with ulcerative colitis. And then being more common in elderly clients. This is something that shows up as being most problematic in pretty much people under 30, young adults, adolescents. So no, that's not more common in elderly clients. The only one of these that is more common in elderly clients is the diverticulitis. And then abdominal tenderness to palpation and left lower quadrant abdominal pain, inflammatory process of the colon. Yes, you are going to see tenderness to palpation and your pain is going to be localized to that left lower quadrant. And we're correct. Moving on. So now our case unfolds a little bit more. In step 3, we have new diagnostic results at 12:10. So let's see what we got. Okay, so we've got a CT scan of the abdomen and pelvis with IV contrast. Now, you're never going to be asked to interpret a CT scan or a chest x-ray or any sort of imaging on the NCLEX if it's something that's outside of your scope of practice. At most, you might see a 12-lead EKG or something that you're expected to interpret, but here, this is going to be given to you just kind of for reference, and you're going to have the interpretation, which here says we've got colonic wall thickening, pericolic fat straining, and sigmoid diverticula consistent with colonic diverticulitis. And you can kind of see here, we've got some of these outpouchings on the sigmoid colon. And so yes, we're correct. We saw that this client has all findings consistent with diverticulitis, and now our imaging has confirmed that. So in question 3, we need to prioritize hypotheses, or remember, determine where do I start? What's most important? What's the biggest risk? Specifically here, we're asked, the nurse is most concerned about the client's risk for developing either a fistula, an abscess, bowel perforation, or contrast-induced acute kidney injury. So these are all actual risks that could occur with this client, but we need to identify what is most concerning. What is going to be most problematic if it occurs? And if you remember from our prioritization framework, we're looking at issues of airway, breathing, circulation, or potential issues of airway, breathing, and circulation. So let's quickly consider each of these. A fistula, that's an abnormal opening between two different places. So you might have a fistula connecting two parts of the intestines. You might have a fistula more commonly connecting the intestine and the bladder, or sometimes even the intestine and the skin. And so obviously if that happens, those two things aren't supposed to communicate. You're going to see bacteria going from your intestines into your bladder, and that could cause a urinary tract infection, which is not good, but it's also not going to quickly cause major problems. And then an abscess. So right where we've got this inflammation at the site of the diverticulitis, you've got a strong local immune response to that area with lots of white blood cells and pus. And so this can develop an abscess where you have this localized collection of fluid. Usually that can make this more difficult to heal and to treat, but unless it ruptures and that pus and inflammatory material goes into the abdominal cavity, this is not as problematic. It's contained. If it's in an abscess, it's contained. Then comparing that to bowel perforation, where if this blocked, inflamed diverticula ruptures, then you're going to have that intestinal content, bacteria spilling into the abdominal cavity. And this could very quickly be dangerous because if you consider, for example, the fact that we can do peritoneal dialysis, where we dialyze someone in their abdomen, that's because that is so vascular. There are so many blood vessels there that if you spill intestinal contents into your peritoneal cavity, it's almost immediately going to go into your bloodstream and cause widespread sepsis and shock. So that does have the potential to be an issue of circulation. And then finally, a risk for contrast-induced acute kidney injury. Now, this client did get IV contrast in order to get this scan. Most often, large volumes of IV contrast in someone who has chronic kidney disease can create a contrast-induced acute kidney injury. He doesn't have any chronic kidney disease when we look at his history here. So this could happen. If it does happen, it's going to take a couple of days of treating with IV fluids where he might have some risk for electrolyte imbalances or further fluid imbalances, but this is not as immediately concerning and as dangerous as if he develops a bowel perforation. So that's the one I'm most concerned about. And we're correct. And then moving on to our fourth question, now we've got new nurse's notes and vital signs from 12:15. So let me look at my nurse's note here. All right, client returned from CT scan and asked to use the bathroom. So he just got this CT, now he's come back to the room. He had one small brown loose stool with streaks of bright red blood. We assisted him back to bed. He reported that moving around and using the bathroom made his pain worse. It's now 8 out of 10 in severity. He is diaphoretic, nauseous, he's guarding his lower abdomen, and he's asking for pain medicine. So we give him an emesis basin, page the healthcare provider, and we're awaiting new orders. And because we're a good nurse, we also got a new set of vital signs because he had this change in his status. And we see that now he's very febrile at 100.8. His pulse is even higher. His respiration's a little bit higher. His blood pressure a little bit higher, but mostly the same, and then his pulse oximetry reading about the same. So remember, keeping our picture in mind, this elderly man now having severe abdominal pain, and he looks sick. In this description, he's diaphoretic. He's guarding his lower abdomen. He's holding an emesis basin. This is a very sick picture of a client with this severe abdominal pain. So keep that in mind. Now we are asked for each potential order, click to specify whether the potential order is anticipated or not anticipated for the client. And so if we've got all of these things going on, pain, nausea, we want to treat the pain and we want to prevent any further fluid losses from vomiting, and we want to relieve his nausea and also make sure nothing worse is going on. But of course, we've paged the healthcare provider and they're going to hopefully come assess this client. So let's take these one at a time. As far as starting a clear liquid diet, when you do have a client with an acute GI complication, it's true that you don't want to give them solid foods. You want to be really gentle, start them with clear liquids, especially if you aren't yet sure whether they're having a GI bleed or not, because anytime you put anything in their mouth, it's going to send more blood to the intestines to digest that food, and that could worsen this problem. So although a clear liquid diet would be appropriate for someone who does have a GI issue, this guy, I'm not putting anything in his mouth. He's so nauseous he's about to vomit, and he's on now hour 4 of vomiting. He's going to get dehydrated. So I'm not going to start a clear liquid diet. I'm going to keep him in PO. This is not anticipated. And then administering antibiotics. Yes, behind that lumen of the diverticulum, we've got swelling, inflammation. This is the GI tract. It's filled with bacteria. Yes, I'm going to anticipate giving IV antibiotics. IV ondansetron, this is Zofran. He's nauseous. This is indicated. I don't want him vomiting anymore. And then giving continuous IV fluids. We already discussed how elderly clients with vomiting like this are really at risk for dehydration. We want to replace some of that lost fluid. So yes, this is anticipated. Hydrocodone PO PRN for pain. We did decide that we want to treat his pain, but again, we're going to make the problem worse if we put something in his mouth. So this is not anticipated. He is in PO. Placing a nasogastric tube to low suction. Yes, we want to decompress the stomach, relieve that pressure on the GI tract, and then also help make him a little bit more comfortable since he's vomiting. So I do anticipate a nasogastric tube. And then transfusing packed red blood cells. This isn't something that we expected to do for just diverticulitis. If I'm not sure, I can review my lab data again where I have a normal hemoglobin level. He's not anemic. So although he has some blood in his stool, even if he's actively bleeding, you don't give blood just kind of randomly. You give blood when it's really indicated, when their hemoglobin is low, when they're anemic. So this is not anticipated. And we answered this correctly. You guys are doing great. All right, so item 5, we've now got our healthcare provider returned our page and we have new orders. So let's see what we got. Maintain MPO status, like we discussed in the previous question, inserting that nasogastric tube to low intermittent suction, giving piperacillin tazobactam, which is an antibiotic, lactated ringers for continuous IV fluids, IV morphine for pain, and then ondansetron for nausea. Good. These are all the things that we decided are indicated for this client. So next, we're asked to address the client's symptoms. The nurse should first blank. Next, the nurse can blank, and we have the same options for each blank here. Administer IV morphine, administer IV ondansetron, and insert the nasogastric tube. So of these, we're going to do one first and one second. So when we're prioritizing, when we're thinking about what to do first, we want to prioritize issues of airway, breathing, and circulation. In this case, this guy has been vomiting, he's lost fluids. We want to stop that vomiting to stop the volume loss and prevent an issue of circulation from developing. So I think of these, I want to prioritize the ones that are going to relieve his nausea. So of those, we discussed how, of course, giving an anti-nausea medicine will do that, and then inserting the nasogastric tube will do that. But what does this look like if I do these things first? Am I going to let this poor elderly gentleman sit here with severe 8 out of 10 now abdominal pain while I'm sticking a tube down his nose? No, I think that's cruel. And also, if we have another tool at our disposal, the IV ondansetron to relieve his nausea, that can work a lot more quickly than a nasogastric tube would. So to give IV Zofran, you just have to get it from the medication machine and give it in the IV. And because it's given IV, it works almost immediately. So that could relieve his nausea without the NG tube ever going in. So I think I'm going to do that first. And then as far as what's next, I'm either going to give the morphine or insert the NG tube. We spoke about how long it might take to put an NG tube in. You have to get your equipment. Usually you have to get someone to help you. You have to insert it. And then before you can ever hook it up to wall suction, you have to get a chest x-ray to confirm its placement. This is going to take a long time. And it's also a really uncomfortable procedure. This is going to make him gag. If we hadn't given the Zofran first, it might even precipitate more vomiting. And it's a painful procedure that, because I have the option to give Zofran, let that start treating his nausea, there's less urgency to get the NG tube in, and I can pre-medicate him with morphine for this procedure. So I'm relieving his nausea, I'm relieving his pain. And yes, we're correct. Now for our final question. On day 2, the day shift nurse, I think that's us, assumes care of the client and enters an updated nurse's note at 7. So let's look at our nurse's notes. All right, so here we are, day 2. The night shift nurse recorded the client woke up reporting worsening abdominal pain and nausea, administered IV ondansetron and morphine as prescribed, and then will endorse reassessment of symptoms to the day shift nurse. Now we come on, received shift report from the offgoing night shift nurse, and assumed care of the client. Client reports relief of nausea, but no relief of abdominal pain following medication administration. Nasogastric tube secure and connected to low intermittent wall suction. And so we've performed our initial shift assessment. We have our new findings. And here we're being asked for each assessment finding, click to specify if the finding indicates that the client's condition has improved or declined. So that's simple enough. We're going to consider each one of these and decide whether it indicates improvement or that he's declined. Abdominal pain, 9 out of 10. Now, he came in at 7 out of 10. He was 8 out of 10 when he came back from CT. This is the worst it's been since he's been here, so that's definitely a decline. Bowel sounds absent. We talked about the quieter your bowel sounds are, the less gastric motility is occurring. They were quiet when he came in as being hypoactive. Now they're totally absent, also a decline. A relief of nausea and vomiting. Well, that's good. He had it 30 minutes ago. It was treated. So probably a little bit of this low intermittent wall suction doing its job and decompressing his stomach, and that Zofran taking effect. So yes, he's had a relief in his nausea and vomiting. That's improvement. And then presence of abdominal rigidity. If you ever hear abdominal rigidity or board-like abdomen, a rigid abdomen, that means most likely your client has developed peritonitis, where maybe something has ruptured and now that inflammatory process is no longer contained to that diverticula in your left lower quadrant, but is now affecting your whole peritoneal cavity, which would explain why his bowel sounds are now absent and his abdominal pain is so severe. So that represents a decline for sure. And then our white blood cell count, 16,200. You'll remember before it was 15,600. And so the higher the white blood cell counts, the worse that inflammation and fever and the worse that inflammation and infection. So this also represents a decline. And that is it. So that is how you approach a next-gen case. I hope you found this helpful. If any of this was unfamiliar to you, please go review our video on approaching next-gen cases and shows you the strategy for how to think through each of these questions. But as you can see, we were able to answer these questions easy enough from a place of understanding the disease processes. In next-gen, there's no real trick to solving these. You just have to understand what's wrong with your client and what needs to happen in order to correct that problem. So keep these things in mind, practice using these strategies, and you guys will be just fine.